that brings us to the last 15 minutes where we've got time for questions. And so I'm going to try and pull some of them together. You've been very good at putting your questions into us. I will try and pull them into groups, and we've got our 4 speakers still with us today. So the first lot would have been on testing. There's a few questions coming about testing. Let me just read them, and then I'll ask the panel if someone wants to pick up on it. So we've had a question about what's the best way to approach testing or diagnosing in a child, particularly if there's additional needs such as autism. A second one in testing is, does NVRL in Dublin test for Lyme disease? Someone else asked, is there any point in doing serology too soon, i.e. before 3 weeks, due to antibodies not yet being present? So would somebody like to perhaps give some responses to those questions?
Okay, obviously, again, going back to clinical history, and if there's a clear diagnosis, the NICE guideline does say that you should be contacting a pediatrician if you've got more than just a simple EM rash. If you've got the EM rash, you don't need the test anyway. Obviously, you treat based on that. If you've got more symptoms than that, you should be referring to pediatricians anyway. And I think often if you were trying to acquire a blood test from a very young child or a child with problems like autism, you'd probably refer into the peds anyway, as they would be more experienced at doing that. But the important thing is not to delay treatment if you think that this is Lyme disease. A phone call probably rather than a routine referral would be far better.
Right, and
taking photos if there are any rashes, definitely.
And in terms of the Irish question, yes, and National Virus Reference Laboratory, all of the laboratories in Ireland test for Lyme. So, but each different, they don't go to one central place. So Galway is different from Waterford, is different from all of the samples from the Mater and from go over to UCD. So they go to different places. But if they're positive, then they're all sent to Porton Downs in the UK. So the UK for confirmation for Western blot. But like I said, the antibody test is not 100%, may not be positive early in disease, may be negative if you go on antibiotic treatment. I've seen people who were negative at 3 months who went positive at 6 months. So the kinetics of antibody response are not totally well understood. Just like the antibody test with COVID, I think people are more understanding of antibody tests now. All of my staff members who had COVID in the hospital in April, when they were antibody positive a month after discharge from the hospital, but 58% of them were antibody negative by 4 months later. So antibodies do not necessarily stay with you for life. And then some people can have a negative antibody that goes positive later. So you should really focus on the clinical diagnosis and use the antibody test, the Irish test, the UK test, or even foreign tests. You should use them to support the diagnosis. You shouldn't use them to deny people treatment.
Thinking now about the rash, there's been a couple of questions about the rash. Are there other late rashes? The one mentioned already. And could you please describe other manifestations of the EM rash, as they're not always a typical bullseye? So a couple of questions there, perhaps for one of our GPs to take on.
I can answer that one. I think there is a real variability in how EM presents. It's not classically bullseye. It can be solid, it can be disseminated, it can look like, from a distance, it can look a bit like a shingles rash. It can be linear, and it's commonly misdiagnosed as ringworm or cellulitis. But the key thing is that it's dermal. It's the immune response to the spirochete, so it's not you have an epidermal chain, and it will evolve over time. It's fascinating that I think some of the different strains can different types of EM, and there are some people that get a very vigorous EM. Some of my slides show within days, florid bullseye rash. Other people, I mean, mine was very, very weak, and it was weeks of later. I've seen other people with EM rashes that are very, very slow, sort of over months, this feeling. So it's so variable, but for the reasons we've discussed, the common feature is that it will migrate outwards and will spread. And sadly, it can also transiently, it can go as well. So there is an opportunity for people to up, and sometimes it will resolve. So it's just about being vigilant, and if in doubt, treat, and or get a dermatology opinion. They could do a biopsy if all else fails. I'd hope we wouldn't need to get to that stage, and treatment by then should really have happened, but that's another option. Dermatologists will biopsy funny rashes. In fact, they love doing that. So,
Anne, would you like to add to that?
Just to say that at first glance, they can look exactly like a cellulitis or an allergic reaction to an insect bite. I've seen so many where it's about the history. It's not itchy, it's not hot. It's when you've excluded those other things, and sometimes that's what you're going on, a diagnosis of exclusion. If you cannot think of any other good reason for this rash.
I'm just going to add with the EM, I've put a link in the chat on an article from Bay Area Lyme where they've got photographs of different examples, but also a diagram which depicts different types of EM rash that can appear. But the thing to remember is it can look different in different people.
Thank you for that, Zara. That's helpful. It's often good to get a look at the kind of photographs and pictures that just help us to keep that open mind. So thank you for those questions on rashes. We've got one here on treatments. In the early phase of Lyme disease, if doxy or amoxicillin can't be used, what is a better option, azithromycin or cefuroxime? As CDC and IDSA recommends cefuroxime and NICE recommends azithromycin. And then there's also a link there to questions about, is antibiotic resistance perhaps a concern? And just some thoughts on how to best manage a Herxheimer reaction.
Right.
Jack.
Okay. So I can just talk a little about that. You know, there's not really been good studies comparing one antibiotic versus another. So doxycycline works, amoxicillin works, cefuroxime works, azithromycin works. So those are your options. You know, and I just think that we don't have. There's no good studies to show they all have activity against Lyme, and they also have, some of them have activity against some of the co-infections, like I said, as Anna's previously mentioned. And then, I mean, people go on, for example, doxycycline or limecycline or minocycline for 2 years for their acne. And it's not really thought to be an issue with resistance, you know, so we don't, since you can't grow these bacteria and you can't measure antibacterial resistance assays, there's really no way of doing that. But to the best of our understanding, these bacteria are slow growing and you don't become resistant to the antibiotics. That's the best information we have, but we've got no studies to prove it.
Okay, thank you for that, Jack. Complex areas. We've got a couple of questions on the wider primary healthcare team there. The obvious one being, how can we ensure this reaches all primary care practitioners? And I think what the question means is this kind of training, because this is clearly voluntary today. And a question about the role of physiotherapists helping in chronic symptoms, or is it purely the antibiotics that work? Anybody like to pick that one up?
Yeah, in terms of wider education, obviously the RCGP has backed the education in terms of the toolkit which is available and the e-learning module. And to some extent it ends up being word of mouth. If somebody can educate the rest of their team, that's important. I think we're happy for people to, I'm certainly happy for people to use my slides if they felt they were useful in educating colleagues. If anyone wants to keep in touch with us in terms of providing, you know, local standard education in line with the guidelines, and you know, that's good. I think educating registrar groups is good in that they can then go back to their teams. And we're hoping that there will be some longer term research going going to be set up. So if anyone wants to get back to us to say we'd like to stay involved, can we keep updated with you, then we're happy to do that. Probably through LRC would be the best way to contact us.
Thank you, Anne. Thank you very much. And I think that there's a few other questions come in, which some of our presenters and some attendees have answered in the way through today. So hopefully you'll be able to pick up on those as well. But on that note, I think it's probably a good point to bring it all to a close now, and to say there is a lot more information available on the Lyme Resource Centre website. We're very much about education of not just the public, but the professionals as well. We're so grateful you've all joined us today. And on there, you'll find things, for example, Dr. Lambert has done bite-sized videos answering a lot of the questions that have actually come up today. So I would encourage you to go when you've got some time and go in and have a look at those. We've done them in short chunks so that they can be done in 5 minutes, 3 minutes, whatever. And a lot of those questions are addressed there. We've also got links there to the RCGP toolkit and to other useful pieces of information for you, leaflets for patients, etc. So I do thoroughly recommend that you go there when you have the opportunity.